Good morning, everybody. It's a real honor for me to be here, and I'm just excited to spend the morning with you. So we're going to get right into it with PAD, an epidemic of medical neglect. And you'll hopefully walk away understanding how you can really make a difference for your patients. So these are my disclosures. None of them are really relevant to today. The work that I do with Boston Scientific and Abbott Laboratories really involves medical educational conferences. So in terms of the objectives for this talk, first, by the end, I hope you'll be able to utilize appropriate diagnostic testing to identify and treat patients with PAD. And second, apply best medical therapy to reduce mortality and limb events in patients with PAD. So we'll start with a case. This was a 78-year-old woman with leg pain who was referred to me. She's a vasculopath. She has CAD, hypertension, COPD, and she's a current smoker. She was complaining of bilateral cramping pain, left more than right when she ambulated any distance. She had leg pain at night sometimes and a sensation of numbness and tingling that radiated from the hip to the foot. Her meds are listed there for you, but I want to call out she was on aspirin, atorvastatin 40 milligrams, and losartan 25 milligrams daily. So her primary care provider got a lower extremity arterial duplex, and as you can see on the right, there was no significant stenosis noted, and on the left, she had a 20 to 49% stenosis in the distal SFA with some plaque visualized, but really no other major obstruction to flow. So the question is, does this explain our patient's leg pain? And how do you distinguish causes of leg pain for your patient? What diagnostic test is going to be most appropriate to help you identify whether or not PAD, for example, is the cause of the patient's leg pain? So like most things, we start with the history, right? So PAD traditionally is described as exertional and reproducible pain. That's intermittent claudication, and it resolves with rest in less than 10 minutes. Spinal stenosis is the great mimicker, and for that reason, pain related to it is called pseudoclaudication. It can be exertional or positional, often with just standing alone, and it's not relieved by rest alone often. Patients will need to sit down, lie down, lean forward to relieve their pain. Lumbar disc herniation is worse with exertion, but tends to linger after rest with some relief after lying down. Osteoarthritis is pain that can radiate, is variable in its onset, and it's not relieved by rest often. And then venous claudication, which most people don't think about, is described as an exertional tightness or bursting pain as the patient has inflow into the limb and not enough outflow. You get almost like an elevation in compartment pressure that causes pain. And this subsides after lengthy rest. It often takes over 15 minutes to go away. Beyond that, PAD has a real spectrum of disease. So up to 20% or so may be asymptomatic. Only about 30% in the literature present with that typical claudication pain. A lot of patients have these atypical symptoms that don't fit the illness script. And then about 10% or so will present with chronic limb-threatening ischemia, the end stage, which is rest pain, gangrene, or ulceration. And this is extremely high risk, as we'll talk about, because 25% will ultimately require an amputation within a year. Now, the other thing to consider is the level of involvement, which is going to really dictate your patient's presentation. So you can see on the right-hand side of the slide, the frequency of involvement doesn't add up to 100% because patients can have multi-level disease. And on the left-hand side, the location of disease. So you typically will have symptoms one level below where the obstruction is. And then the symptoms will depend a lot on collateral flow. So in the aortoiliac regions, collaterals are typically pretty well developed, but if patients do have significant symptoms, the revascularization options have very high patency rates. Down in the femoral popliteal region, the profunda is the great collateral, and that will dictate the patient's presentation a lot. And our patency rates for revascularization are lower than the aortoiliac, but better than below the knee. Below the knee are typically the area where we have our diabetic, CKD patients with disease. There's very low patency rates in this area. Patients will present with calf or foot claudication or pain.
Let me hold on.
So how do we determine whether or not a patient's limb is getting enough perfusion overall, taking into account all this collateral flow? Well, the ankle brachial index is the cornerstone of diagnosis for PAD because it's going to tell you about the overall perfusion to the foot,
since I can't
taking
do
into
it through
account
the
all that
bank.
collateral flow.
And
the way that we calculate that is we take the highest ankle systolic pressure between the dorsalis pedis or posterior tibial over the highest brachial pressure between the right or left arm. And we do that for each leg. We use a Doppler sensor to see exactly when flow comes in after we occlude with the cuff. And when you look at the sensitivity and the specificity, the ABI outperforms the pulse exam and the Rose questionnaire, which is symptoms of claudication, reproducibly. So it is the best tool that we have for the diagnosis of PAD.
No.
Now, how well do internists do at screening and diagnosing patients with PAD? Well, there isn't a lot of data out there, but there is this study from 2013 published in the Vascular Medicine Journal. It included or invited over 1,000 GPs in Australia to participate in a survey about their practices.
Can we let it go?
About 26% responded, and the majority used history and examination, followed by the ABI and duplex ultrasound. But when providers felt that the patient's history and physical exam was consistent with PAD, the majority would go to duplex as a first-line diagnostic tool. And usually this was because of lack of time, training, or skills in their practice. The younger GPs under age 40 were more likely to use the ABI over duplex, probably because of improvement in our education and getting providers ready to care for these patients. But when you think about the available diagnostic testing in PAD, again, the physiologic testing, the ankle brachial index, and we're going to talk about the other additions to the ABI, really tells you if there's an arterial flow problem for your patient. The imaging is going to allow you to see the lesion anatomically, but it's not going to tell you if it's responsible for your patient's symptoms. So when you're thinking about physiologic versus imaging testing, either ABI or imaging will tell you if your patient has PAD. It'll identify plaque in the limb. If you want to know where it's located, imaging is probably going to be better than physiologic testing. But if you want to know how it relates to your patient's presentation, physiologic testing alone will tell you that. When we consider therapeutic options, the imaging is going to outperform physiologic testing. And we're thinking about whether or not our patients actually improved from the therapy we gave them. The physiologic testing will tell us that. So again, coming back to the ABI, the threshold for abnormal is an ABI of 0.9. Borderline is considered up to 1. Normal is 1 to 1.4. And then in patients with calcific disease, diabetics, end-stage renal disease, when the ABI is greater than 1.4, the ABI is no longer accurate, and we have some other tools that we can use in that setting. But I want to spend just a moment to use this as an example of calculating an ABI. So we have a right brachial pressure of 160, left of 120. We said we're going to take the higher of the two, and this nicely illustrates why. We have a pretty big gradient between these two limbs. There's left subclavian axillary disease, okay, because there's a difference of more than 20 millimeters of mercury between the right and left arms. So that's why we take the higher brachial pressure always when we do this. And then if we go to the right leg, the higher of the ankle pressures is 80 from the dorsalis pedis. So our ABI on the right, 80 over 160 is 0.5, which is abnormal. On the left, the higher ankle pressure is 120. 120 over 160 is 0.75, which is also abnormal. And the reason we use the higher between the ankle pressures is because it's the most specific for the presence of disease. Now, there are some inherent limitations to just an ABI. It doesn't localize the level of disease, number one, right? It tells you there's a blockage somewhere between the arm and the ankle, but not much more. How do we get around that? Well, we can get segmental pressures. We can get multi-level pressures to help identify the level of disease. And I'll show you an example of that. What about variability between exams? At what point can we say a patient's actually getting worse or better? Well, you're looking for a change of 0.15 or more, and that's considered significant between exams. What about this calcification and non-compressibility that I mentioned for our diabetics and end-stage renal disease patients, or when the ABI is greater than 1.4? we can actually obtain the toe brachial index, which uses the great toe pressure versus the brachial pressure, and abnormal is less than 0.7 in that setting. And then what about our patients with mild disease? There's probably poor sensitivity in that, right? If it's normal at rest, does it really mean they don't have PAD? Well, just like cardiac testing, you can do exercise testing to bring out disease if the resting ABI is normal, and actually see if you can reproduce their symptoms of claudication. So this is an example of what segmental pressures look like. Essentially, most institutions will use this 3-cuff method, which is a thigh cuff, below knee, and then ankle. And it's paired with a continuous wave Doppler, which is taken at the level of the groin. And you can see the continuous wave Doppler waveform at the bottom. So to identify the level of disease, you first calculate the ABI, and after you determine it's abnormal, you look for a drop in the pressure of 20 to determine the level of disease. So using this as an example, the higher brachial pressure, 146 on the left, is compared to 125 on the right. So we're going to use 146. And of the two gives us an ABI of 0.87, which is abnormal. On the left-hand side, the higher of the ankle pressures gives us an ABI of 0.83, which is also abnormal. So now we want to find the level. If we go from 146 to 143 in the right thigh, we're still within 20 to 114. There's our drop. And it doesn't have a further drop after that. We see the same level of drop on the left side. So this patient has bilateral femoral popliteal artery disease. Okay. So now you see waveforms on the side here as well. These are pulse volume waveforms. So the cuff, when you do an ABI, is partially inflated, and it's measuring the volume displacement of blood flow. That mirrors this, the continuous wave Doppler with the triphasic waveform. So a normal waveform should have an upstroke dicrotic notch and be triphasic, as shown here. The first thing to go in the presence of disease is the dicrotic notch. Then it becomes parvus tardus, and then very abnormal. So it's an adjunct to the pressure, but the pressure is always more accurate than the waveforms. Okay, this is the last ABI example to show you for exercise therapy. So in this case, we've got a brachial pressure on the right of 140, which is the higher of the two. Our ABI at rest on the right is 0.9, the highest ABI, which is just abnormal. On the left side, we have a big discrepancy, 1.24 for the posterior tibial versus 0.66. Pretty big difference there, right? So this patient happened to have CKD and diabetes, so we obtained the toe brachial index. We took the great toe pressure and the brachial pressure, and both of these toe brachial indices are less than 0.7, 0.51 and 0.38. So what's happening here? Why is the ABI kind of close to normal, but the TBI is so abnormal? Well, with calcification, you can get a falsely normal ABI, okay? Because as it becomes calcified, it becomes more difficult for that cuff to compress it. This patient was complaining of claudication, so they were exercised on a treadmill, and with exercise, the ankle pressures dropped. So on the right side, we went from 126 to 85 and 174 to 119, demonstrating that this patient has significant disease, limiting their ability to ambulate. And this is just a slide demonstrating that even patients with chronic limb-threatening ischemia, an ulcer, a wound requiring revascularization, a significant number will have a falsely normal ABI because of that calcification. So if you have a patient with a wound, you get an ABI and it's normal, that may not be the end of the story. You may need to dig deeper if it doesn't fit the clinical picture. So this is the toe brachial index, really tiny cuff, with photoplethysmography to identify the pressure in the waveform. The reason this works is because the small vessels are not subject to calcification in the way that the larger vessels are. So this is the tool to use when you suspect calcification or when your ABI is not normal. So coming back to the first patient that we saw who had the 20 to 49% stenosis in the left leg and symptoms of pain that varied with different rates of ambulation and sometimes at nighttime. This is her ABI. So we've got an ABI that shows 1.08 on the right, 1.1 on the left, so both are normal at rest. Her waveforms look pretty okay. She's got a little bit of a dicrotic notch there, but she's reporting pain with ambulation. So she gets exercised. She ended up stopping because of leg pain, left more than right. But if we look at her pressures on the left, they actually went up with exercise, and her ABIs after exercise remained within normal range. So her pain is not due to PAD, although she has PAD. We actually saw a plaque on her imaging. So this is an opportunity for us to optimize medical therapy, not to go down thinking we need to treat this lesion, 49% stenosis. So what are our treatment goals for PAD? Well, they're really threefold. We want to prevent MACE, prevent MAL, limb events, and improve symptoms of claudication for our patient. We're going to focus a lot on the first two in this talk. And this is what all the fuss is about, basically. There's a lot of reproducible data that CV risk increases with a decreasing ABI. So what you can see is non-fatal or fatal MI on the y-axis and your ABI shown here. Now, simply an abnormal ABI of 0.9 gets you an event rate per year of 2%. If your ABI is less than 0.7, 3.8%. So if you carry that out to 5 years, your risk is 10% with an abnormal ABI, almost 20% if your ABI is less than 0.7. And if you translate that into Framingham risk, which defines 20% at 10 years, every single patient with PAD is very high risk for cardiovascular events, okay? And we should be treating them appropriately. And the reality is we just don't do that. In terms of epidemiology, the rates of PAD are rising. So as of 2010, there were more than 200 million patients around the world with PAD. And this was a significant increase in both our older and younger patients. And again, if we look at the outcomes of MACE and MAL for just a diagnosis of PAD, including asymptomatic patients, not CLTI, the rate of non-fatal stroke or MI is 20%. 15% will die because of a cardiovascular event. For limb events, 1% to 2% will progress to CLTI, and 20% will get revascularized over a 5-year follow-up. It's even more dismal for patients with chronic limb-threatening ischemia, which again is gangrene, rest pain, or ulceration. Accounts for about 10% of patients overall. At 1 year, 50% will be alive with 2 limbs. 25% will be dead. The other 25% will have an amputation. So it's horrible outcomes. And this was really interesting data looking at 5-year all-cause mortality of CLTI and major amputation compared to other diseases. And you can see that CLTI, major amputation, higher rates of mortality than all cancer. And if you look at where our healthcare dollars go in terms of research and all of that, I can tell you it's definitely not going to PAD. So it's a shame. But there's been a lot of work and advocacy on this, and I'll just update you on that. But I want to pause and just comment on the disparities in PAD as well. So African Americans have 4 times the amputation risk when it comes to PAD. There's definitely a connection with poverty. And our patients with CLTI and combined Medicare and Medicaid, they have higher mortality and amputation compared to those with Medicare alone. And then there's geographic differences, much higher rates of amputations in the southeast central US as compared to the mountain areas, for example, and much lower rates of amputation-free survival for our Black patients. So this was just released at AHA in 2023 and recently published. The AHA developed the National Action Plan for Peripheral Artery Disease to improve awareness, diagnosis, and treatment of PAD. There's 6 arms: public awareness, detection and treatment, research, professional education, public health, and advocacy, with a goal to improve these horrible outcomes for our patients. One of the first things that this group did, which is really a coalition of major stakeholders from different professional societies, including the surgeons, medicine, cardiologists, et cetera, and the Diabetes Association, the ADA, for example, is to try to implement opportunities for us to change policy. And so they produced this non-traumatic lower extremity amputation by congressional district heat map. of the US. And you can access this online. You can look it up by county, state, to see how your area is performing. And the hope is that this will be used to inform why some areas are doing so bad. Is it a matter of access to care? What is going on to make such a big difference between the Southeast and Central US compared to the rest of the country? When it comes to screening guidelines, there are things that we can be doing if we follow what's already out there. This is from the European Society for Cardiology, AHA and ACC, and they advocate for screening patients for PAD if you're over the age of 65, or if you're 50 to 64 with diabetes and one additional risk factor, or if you have atherosclerotic disease in another vascular bed. If you're less than age 50 and you have diabetes and one additional risk factor, you should be screened as well. This is in direct contradiction to what was recently published by the US Preventative Services Task Force in 2018, who said that basically there's not enough evidence to say whether using the ABI to look for PAD is beneficial for adults with no symptoms. And I have a few comments on this because I know how important these publications are in terms of informing our practice. So first is that during the open commentary period, there were many recommendations from multiple societies that came together in a detailed 10-page letter that was really ignored. In addition, we know that PAD patients have lower functional status that may not be reported. Patients tend, and most people tend to avoid pain. So they often will limit their ambulation or lifestyle to avoid symptoms without even realizing they're doing it. And sometimes you need that objective testing to show you the patient has PAD. Almost a third of the patients that were used in this publication were authored by the Agency for Healthcare Research and Quality, which is the USPS TF mother organization, but other quality references on screening benefit were ignored or not included. They ended up comparing the ABI to MRA and reported poor sensitivity, but I'll take you back to the beginning of my talk. MRA is not the gold standard for diagnosis, the ABI is. So it's not really an appropriate comparison. We know that there's clear benefit to cardiovascular risk reduction when we use guideline recommended medical therapy for our patients with an abnormal ABI. And lastly, they said that there was a potential for harm with additional testing if you've identified PAD in a patient with no symptoms, for example. But the reality is we don't need additional testing if the patient doesn't have symptoms. You can stop at the ABI, put them on maximal medical therapy, and stop there. You don't need to get additional testing. And I'll just bring you back to this. Every single patient with PAD is very high risk and should be treated appropriately. So this is the summary slide of what our guideline-directed medical therapy is. We have a lot of level 1 evidence to support this. For our antiplatelet therapy, at minimum, patients should be on aspirin, or I'll make an argument for clopidogrel in our symptomatic patients later on in my talk. All patients should be on a statin with LDL less than 70. Very important. For our patients with hypertension, we should be targeting blood pressure less than 130/80. And there is evidence to support the use of an ACE or an ARB in these patients. Smoking cessation should be advised. Cilostazol is an effective therapy to reduce symptoms for those that can tolerate it. And then supervised exercise is recommended and now approved and paid for, and we should be referring patients for this. So I want to pause and just give the diagnosis or the definition of medical negligence, and that's when a healthcare provider fails to follow recognized standards of care and causes preventable harm to the patient. And this really is an epidemic in the field of medicine. And here's some data to support that. So looking at NHANES data, the US PAD prevalence was 5.9% in 1999 to 2004, or 7.1 million adults with PAD. And what you can see is the reported statin use, ACE, ARB, and aspirin use was in the 30s. For patients who had multiple preventative therapies, there was a 65% lower all-cause mortality. So these therapies work if you use them. Now you might say, well, this is old data. I'm sure we're doing better. I wish I could tell you that was true. This is a more recent publication from 2017 that looked at data from the National Ambulatory Medical Care Survey and National Hospital Ambulatory Medical Care Survey, between 2006 and 2013. And what you can see is PAD alone is the blue bar, PAD with CAD is the red bar. Patients are treated better if they have both PAD and CAD. But regardless, we're still in the 30s to 40s for medical care for these patients, which is really just horrific. Now, what about even our end-stage patients? We must be doing what we can for them, right? Well, this is 2 recent chronic limb-threatening ischemia trials, BEST-CLI and BASIL-2, and I pulled out the medical therapy from each of these trials. These are patients who are getting revascularized, right, for gangrene or amputated. Antiplatelet therapy, only about 70 to 80% at most. Lipid-lowering therapy, 70s. Nobody should be getting on anybody's table if they're not on a statin. In terms of our lipid and hypertension control guidelines, again, we know that treatment with statin is indicated and that antihypertensive therapy should be administered with the use of an ACE or an ARB, which may actually reduce ischemic events. So what statin should you be using? Really, you only should have a atorvastatin 40 to 80 or rosuvastatin 20 to 40 in your armamentarium, but I would just say start something. 30% are not on anything, so just put your patient on any statin to start. There is some data for the PCSK9 inhibitors. This was the PAD subgroup from the Fourier trial, which included over 27,000 patients. They included PADs identified by intermittent claudication and a reduced ABI or prior revascularization. A lot of these patients were on the maximum tolerated statin therapy, pretty good numbers as you can see there. But when you look at the outcomes of reduction in CV death, MI, or stroke, those with PAD had a number needed to treat of only 29. So significant reduction with PCSK9 inhibitor use. Additionally, there was a reduction in MACE or MAL for these patients, number needed to treat of 25 for patients with PAD. There was no safety concerns or adverse events, and the limb benefits persisted even at very low LDL levels. So we definitely can apply these therapies to our patients to get their LDL to goal. In terms of hypertension, the data for ACE or ARB comes from the HOPE trial, which was a trial comparing ramipril versus placebo in patients without heart failure. 42% of the patients included in this trial had PAD. And what you can see is a reduction in almost every outcome, at least cardiovascular outcomes, with the use of ramipril 10 milligrams versus placebo. And so for that reason, if your patient with PAD has hypertension, I would absolutely apply ACE or ARB therapy to their prescription. The antiplatelet therapy guidelines are confusing. I'm going to try to break it down to a digestible level. But essentially, the current guidelines say that it's reasonable to use antiplatelet therapy for asymptomatic PAD. You can use aspirin or clopidogrel for symptomatic PAD. The effectiveness of dual antiplatelet therapy is not really well established, but we will have new guidelines that are going to be coming out later on this year that will also incorporate the new COMPASS trial data, which we'll review briefly. So going back in time, the data for aspirin versus nothing comes from the antiplatelet trialist collaboration that was published in the 90s. The other high-risk group shown here were patients with PAD. The majority of antiplatelet therapy was aspirin, and it showed a 32% reduction in stroke, MI, or vascular death with the use of aspirin therapy. And so for that reason, at minimum, aspirin should be used. Now, for patients with symptomatic PAD, Capri supports the use of clopidogrel monotherapy. This was a study of almost 20,000 patients with stroke, MI, or PAD that were followed for nearly 3 years. And there was an overall risk reduction with clopidogrel compared to aspirin at follow-up. And it really was carried by the PAD subgroup. And so for that reason, in my practice, patients with symptomatic PAD get clopidogrel therapy. What about DAPT? Well, the Charisma trial looked at patients with PAD. This is, again, the sub-trial of patients with PAD who received DAPT versus only aspirin. There was no reduction in the composite endpoint, but there was a reduction in MI and hospitalizations. It came at an increased risk of bleeding. And this is a trend that we're going to see for these patients. Number one, most of the data for PAD comes from larger coronary trials, and we do subgroup analyses. And so shown here, because ticagrelor had suggested some benefit in the coronary trials over potentially clopidogrel. In the PAD subgroup, this was also becoming a question. So ticagrelor and aspirin versus aspirin, significant reduction in MACE with ticagrelor. Ticagrelor and aspirin versus clopidogrel and aspirin, no significant reduction in MACE at an increased risk of bleeding. So these two finally went head-to-head in the Euclid study, ticagrelor monotherapy versus clopidogrel, and ticagrelor was not superior. So P2Y12 inhibitor for your symptomatic patient, doesn't matter which one. That's the takeaway. So that brings us to the COMPASS trial. Now this was a landmark study. This was a study looking at low-dose rivaroxaban, 2.5 milligrams twice a day with aspirin, rivaroxaban 5 milligrams twice a day, or aspirin only. The PAD subgroup was about 7,500 patients. It included patients with carotid disease, as well as intermittent claudication and abnormal ABI or prior revascularization. The trial was actually stopped early because there was superiority in the low-dose rivaroxaban and aspirin group after 23 months. And what it showed was a reduction in the composite cardiovascular death, stroke, and MI in the low-dose rivaroxaban and aspirin group compared to aspirin alone, not significant for rivaroxaban versus aspirin. It also showed a significant reduction in major adverse limb events, 46% reduction with low-dose rivaroxaban and aspirin versus aspirin alone. However, again, it comes at an increased rate of bleeding. Right, so ISTH major bleeding was increased. It's a pretty conservative bleeding definition, but bleeding into a critical organ was not significantly increased. So finding that margin of benefit for your patient with increased ischemic risk versus bleeding risk becomes important for the use of this therapy. But the limb events with PADs becoming recognized more and more as a really important outcome that we need to be aware of. And really, after your patients have lower extremity revascularization, it represents a turning point in their disease. So it's important for your claudicants that you're careful about who you refer, and this is why. After lower extremity revascularization, it's been reproduced in multiple different studies that there's a fourfold increase of acute limb ischemia for patients. You can think of acute limb ischemia as analogous to a STEMI, but with worse outcomes, right? So really, time is muscle in both conditions. It's an acute thrombotic occlusion, but the mortality after acute limb ischemia is 12% compared to 8% with a STEMI. MACE, 11.7% compared to 3.4% with a STEMI. Acute limb ischemia recurrence, 24% at 1 year, and amputation, nearly a third of patients. Heart failure at 1 year, 7.4%. Yet somehow this doesn't get the same kind of bluster or attention as it does in the coronary space. And after you have acute limb ischemia, most of your events after that are limb related. So again, amputation rates 27% and revascularization nearly 2/3 of patients. So you're committing your patient very likely to repeat procedures after they undergo peripheral revascularization. And this started getting a lot of attention in the lay press last year. Some of you may have seen this. There was a publication in the New York Times about patients who had undergone repeat revascularization. Now, the content of the article focused a lot potentially on bad actors in the peripheral space, but it, I think, did a disservice because it didn't stratify patients with CLTI versus intermittent claudication. Regardless, patients we send for revascularization procedures, we need to be really thoughtful about who they are. So what is the optimal medical therapy after intervention, and how can we prevent these poor outcomes? Well, I mentioned there's no high quality data that DAP's effective. We've got subgroup analyses from coronary intervention trials showing reduced ischemic risk, but it increased rates of bleeding. Charisma didn't have a statistically significant benefit. There were 2 very small trials for endovascular revascularization and bypass. One was stopped early due to poor enrollment. The other had no difference in adjudicated ischemic outcomes or bleeding. So we really have no data on DAPT for PAD. However, if you look at the package insert for the approved devices after revascularization, the recommendations for DAPT are kind of all over the map, anywhere from 1 month to 3 months. So that brings us to the Voyager trial. This study was looking at low-dose rivaroxaban with aspirin versus aspirin alone after peripheral revascularization. And for the reasons I outlined, it didn't compare low-dose rivaroxaban and aspirin to DAPT, which was one of the main criticisms of the trial. But these patients were referred. Here's the breakdown of the patients. Up to 50% ended up getting clopidogrel therapy on top of their assigned treatment group. And it was pretty fair in terms of reasons for revascularization. About a fifth were getting revascularized for critical limb ischemia, and 2/3 were endovascular. Now, what it showed was a reduction in the primary outcome of cardiovascular death, acute limb ischemia, major amputation, MI, or stroke with low-dose rivaroxaban and aspirin compared to aspirin only. There was a reduction in acute limb ischemia by itself, although again, it came at an increased risk of bleeding. There was no incremental benefit with the addition of clopidogrel. And they actually did a sub-analysis of clopidogrel in the Voyager trial. And what you can see is the KM curves for patients with clopidogrel on top of their therapy versus without. And there was no difference in the absolute risk reduction with the use of low-dose rivaroxaban and aspirin, despite the use of clopidogrel therapy. So we shouldn't be withholding this low-dose rivaroxaban therapy to our patients if they're on clopidogrel. It doesn't seem to affect the outcome. And I'll talk about the added bleeding risk now. So they did look at bleeding. If you were on clopidogrel therapy for 1 month or less, there was no increased risk of bleeding. You could do triple therapy. After 30 days, that's when the bleeding rates went way up. So you could do aspirin, clopidogrel, low-dose rivaroxaban for a month, and then drop the clopidogrel. The reality is the interventionalists are usually the ones making these decisions, not us. So you have to work together with them. I think the new question is going to be, like in the coronary space, should we be doing clopidogrel and low-dose rivaroxaban and omit the aspirin? And maybe that will reduce the bleeding risk. We have good data too that using this low-dose rivaroxaban in addition to aspirin reduces first and subsequent vascular events. So you can see with each subsequent event, the rivaroxaban group was lower compared to placebo. So this is a nice summary that was published in JACC in 2018. I have a small modification to the treatment algorithm as shown there. But if you have a symptomatic patient, I would consider low-dose rivaroxaban with aspirin or clopidogrel monotherapy. If your patient's getting revascularized, you can do the clopidogrel on top of that low-dose rivaroxaban for up to a month, and then drop the clopidogrel after that point, again, working together with the interventionalist. But that's what the data shows has the best outcomes. So moving on to some other therapies very briefly, I just want to call out that glycemic control can be beneficial in our patients with CLTI to reduce limb events. Again, there's some subgroup analyses from these trials with newer agents, including the SGLT2 inhibitors and the GLP-1 agonists as well. With SGLT2 inhibitors, there's a reduction in cardiovascular death in the PAD subgroup. With the GLP-1 receptor agonists, there was a lower rate of amputation. So we can absolutely apply these to our patients with PAD. So what about managing the patient with claudication and improving symptoms? Appropriate use of cilostazol. It needs to be given as 100 milligrams twice a day up to 3 to 6 months to reach its full effect. It's important to know that up to 2/3, if the patient can tolerate it, will have an improvement in their walking outcomes, but up to 2/3 don't tolerate it. And that's because of side effects of GI effects, headaches, and dizziness. And there's a black box warning in patients with heart failure. Exercise therapy definitely can improve functional status, quality of life, and reduce leg symptoms. And supervised exercise should be offered if you can. It's now approved. It requires a face-to-face encounter. But then you can get up to 12 weeks, 3 sessions a week for your patient. This is how you order it here. So it's through cardiac rehab. You put in the consult to cardiac rehab in Epic. The reason for referral, intermittent claudication, lower extremity revascularization, and then the patient can call for an appointment and they will get exercise therapy at Sinai. So definitely something you can incorporate into your practice. Some patients can't do the in-person supervised exercise, and so this is what I will tell my patients for a home program. 3 to 5 days a week, up to 50 minutes. They have to walk fast enough to get that claudication pain that stops them at 2 blocks. stop and rest, wait for it to go away, and then go again. So it takes a lot of commitment on the patient's part to walk through that pain, but it really does work. And it's important they get that ischemic pain. That seems to be very important for outcomes. So what about revascularization? When should you think about it? Well, most cases, endovascular first is an accepted strategy, but we have some new data that that's probably not true for every patient. The things to consider include anatomy. The interventionalist will use this task classification. I'll show you an example of what that is. That's a way to define how complex the procedure will be. You want to keep in mind that your patency rates decrease as you move down the limb. So in the aortoiliac area, you may actually revascularize up front because the patency rates are so good. Femoral popliteal, I would do it after they really fail a true trial of medical therapy. Below the knee, you don't send them for revascularization just for claudication, only for CLTI because the patency rates are so poor. This is an example of what the task classification looks like for the aortoiliac region. A to D, D being the most complex, and it's a way that the proceduralists use to identify how complex a procedure would be endovascularly and whether or not a patient maybe should get an open repair. They also will sometimes use this angiosome concept for our patients with wounds. The idea being that there's certain distributions of the limb that are perfused by specific arteries. So depending on where the wound is, they may target revascularizing that specific artery. Again, with the goal in CLTI being just to save the limb, not expecting that it's going to stay open forever. What about surveillance? So if your patient's symptoms are stable on follow-up, they say there's unclear benefit. I do it because, again, patients don't always report accurately how limited they are. If your patient has new or worsening symptoms, you want to get that physiologic testing to prove that they can't walk as far or they've got a new drop in their ABI. After revascularization, it's really a combination of physiologic testing and duplex ultrasound in follow-up. And duplex ultrasound can allow us to identify problems early. It's low risk, non-invasive. Here you can see there's a stent in the artery on the SFA. There's incomplete filling of the stent, and there's a stenosis here. So I'll just remind you about what we talked about. We're getting now to my summary slides to remember when to use physiologic versus imaging in the evaluation of your patient. Remember, the physiologic testing is going to show you how the disease relates to your patient's presentation and how they're doing after therapy, whereas the imaging will really allow you to identify therapeutic options and see the lesion itself. You want to make sure that you use diagnostic testing to identify patients early, remembering the ABI is the gold standard. Revascularization of the claudican is really a turning point in their disease. Remember, those patients are going to come back for repeat procedures, and there's 4 times the risk for acute limb ischemia after revascularization. Our medical therapies are excellent at preventing cardiovascular and limb events. We need to prescribe them. And you can consider revascularization when your patient is limiting claudication despite true optimal medical therapy and exercise therapy above the knee. And in CLTI, it's first line to save the limb regardless of the disease level. That's your guideline-directed medical therapy. And I thank you very much for your attention.